Hello. This this lecture is on chapter 60 which is the orthodontics topic. So this is found in your modern dental assisting textbook in the 13th edition, and this can be found on page 928. Again, it's chapter 60, orthodontics, and I'm Dr. Samara Rashid. Some of the learning objectives that we'll be dealing with today will be talking about the benefits of orthodontic treatment and explaining the roles in regards to what does the orthodontist do and what does the orthodontic assistant do as well. We want to talk about specialized instruments and the accessories we use in them. And just to discuss, nowadays we have a lot of clear aligner treatments that are going on, for example, Invisalign. So we do want to talk about the clear aligner treatment and its effects on orthodontic alignment. So orthodontics is a specialized branch of dentistry, and it deals with the diagnosis, and it also prevents and it also treats dental and facial irregularities. But it provides the following types of treatments, and that's you want to align the upper and lower jaw, you want to correct the bite. You also want to kind of, fix any type of crowding or if there's any space involved with throughout the teeth and it's spread out. And you want to overall straighten the teeth that are rotated, maybe even tilted, or otherwise just not properly aligned. So a lot of people think it's just about straightening teeth, but they're forgetting it's also jaw issues or bite problems. So there's a lot of issues involved when it comes to orthodontics and and fixing them. So what are the benefits of orthodontic treatment? And some of the benefits of orthodontic treatment deal with obviously when you're dealing with the bite issue or fixing or straightening the teeth out, you're also helping the psychosocial aspect or the psychosocial problems that patients have to go through when they're suffering from such issues. So severe malocclusion and dental facial deformities can be a social handicap. Maybe some people won't smile, right? Maybe they're not going to smile when they talk to their friends or they go to gatherings, or when they laugh, they'll put their hand on their teeth because they want to cover their teeth because they're embarrassed. So there is a psychosocial aspect to this. Also, oral malfunction. There are also people that have TMJ issues, and it's difficult for them to chew or, to masticate on their food. So malocclusion can compromise a lot of issues and can deal with a lot of aspects when it comes to the oral function. And then, of course, you have dental disease. And dental disease, malocclusion, can contribute, when you have overcrowding of teeth, and they're kind of tilted onto one another or they're impinging on one another. What happens is when these patients chew on something, there can be things that are getting stuck more often, which then leads to decay, because that type of a patient dealing with that type of an issue will be more prone to getting cavities or decay than someone that has straight teeth, for example. And then what happens also is that they can get a lot of impaction of food between teeth. So it gets really embedded in those spaces, or rather the lack of space that they have, causing periodontal disease as well, because they're going to get more bleeding in the teeth. It's going to be harder for them to clean their teeth. So that's something to think about. Okay. Of course, we want to think about the office and the team when it comes to an orthodontist office or an orthodontist clinic. First of all, you have the orthodontist, then you have the orthodontic assistant, and then you have the orthodontic office on the whole. So the orthodontic office is basically an open bay area, very similar to a pedodontist or a pediatric dentist. It's an open bay area, and I think I have a picture of it here like this. So this is an open bay area here. And as you see, they're not facing one another, and they're not facing, the computer area. They're kind of facing this way, but this is the open bay concept. The orthodontist works closely with a pediatric dentist and a general dentist. Okay. And what their training entails is a 3-year specialty training after they finish dental school. Okay. So it's 4 years of dental school, and then they have to do 3 years of orthodontic training. And they ultimately have to pass an exam, because what field doesn't have an exam, right? So they have to pass an exam by the AAO, or the American Association of Orthodontists. So the orthodontic assistant has to be a skilled assistant that has many expanded functions, like placing brackets, doing impressions, taking records, And you also have to take a Danby exam. And then you also definitely have to consider autonomy with expanded functions. But the orthodontic office overall is an open bay concept. You also have to think back to DNA 113 when we talked a little bit about occlusion. And I believe this is also discussed in DNA 108 or dental science. You'll remember we talked about the occlusions. So you remember class one. Let me see if I have a picture of it. I might not have that. But you have a class one or a class two occlusion. And it was all dependent on the mesiobuccal cusp of the first molar. So regardless of the occlusions that the patient has, most malocclusions are basically caused by hereditary factors. Okay. You can inherit your teeth from from one parent, but then inherit the jaw orientation from another parent. So it's not like, oh, I inherited this from, a whole set, the jaw with the teeth. So that's something to consider. So most malocclusions are caused by hereditary factors that affect the disproportionate jaw size between the upper jaw and the lower jaw and the size of the teeth. And orthodontic problems result from interaction of developmental, genetics, environmental, and functional influences. So, no matter what, let's say you're nail biting, right? Let's say you chew on a pen. Let's say you do something like that. And ultimately with time, maybe you'll develop what do you call that? Like a slight divot or a slight I guess you can call like an indentation of your teeth of your teeth. So, and then that would result in some sort of crowding. Hold on a second. So yeah, so you have to consider certain things. And I mean, even when you look at your own teeth, you'll smile and you'll notice maybe your jaws, the jaw size or something is inherited from one parent or the orientation is inherited from one parent. But when you look at your teeth and the shape of them, maybe you can acknowledge that you've inherited this shape of your teeth from this parent. So it's just something to consider. So what are some developmental causes resulting in malocclusion? First of all, you can inherit missing teeth. Let's say a mom inherits the fact that she doesn't have lateral incisors, for example. So she's missing number 7 and 10. So she, maybe her child, then she passes that on to the child such that when they're in their teenage years, they look in the mirror when they smile and they notice, hey, I don't have lateral incisors, for example. So, that's something you can inherit. Malformed teeth, that's something that's also developmental. Okay, supernumerary teeth. Anybody remember what that is? Supernumerary teeth are extra teeth. Interference with interruption. Let's say you lost a primary molar early in life, due to, I don't know, trauma or a deep cavity and you had to get it removed. And then the teeth kind of crowded in, the baby teeth crowded in. And unfortunately, the permanent tooth below in the jaw was unable to erupt. So there's an interference with eruption. And then there's also ectopic eruption. A tooth has now erupted in an area where they weren't supposed to, due to who knows what cause, but it's like jutting out of the palate, alongside the palate, for example. So all of these are due to congenital defects. Another example is failure of a tooth bud to develop in the mouth. Let's say wisdom teeth just never developed. Adverse effects from another disease. Maybe they have some issues because of a certain disease that they have. So when it comes to genetics, we all know it's beyond the control of the patient. Okay, it's inherited. That's not something, that they can control. So a child who inherits a mother's small jaw and a father's large teeth may have teeth that are too big for the jaw, causing overcrowding, or maybe the teeth are too small for the face. And then we have things that we try to control. We have injuries. Anything from birth injuries can occur in two major categories. We can get fetal molding, like the limbs are pressed against the growing structures that prevents growth. Let's say the baby was in the mom's womb, and like the child's hand, the baby's hand was kind of resting on the face a little bit, right? That can happen. Trauma during birth. Let's say the doctor decided to use forceps, putting pressure on structures. Let's say like a broken jaw or a fractured jaw when trying to take the child out. because when it comes to getting your child to survive, the baby to survive, you're gonna, the doctor's got to do whatever they can to get the child out to make sure they survive. So sometimes you can have a traumatic birth experience, sports injuries, car accidents, dental trauma and malocclusion, like premature loss of teeth, missing teeth, or even teeth that are just impacted, like wisdom teeth. Habits causing malocclusion. I think we talked about, like, things like if you're chewing on a pen, let's say you're a natural tongue thruster, like naturally your tongue thrusts against the lingual surfaces of your anterior teeth. Let's say when you swallow, the tongue thrusts, a little bit more than normal against the teeth when you swallow. The thumb and finger sucking, those people that, suck on their thumb, those children. Bruxism, which is grinding of your teeth, and mouth breathing. Let's say they just naturally breathe through their mouth. And just a little bit of a picture here that I posted. This is your tongue thrusting habit. And you can see here, look what's happening. The teeth in the back are occluding properly, but then you look at the front, look what's happening. It has left the patient with an open bite. They call this an open bite, and which can be fixed. And that's why we have ortho treatments. And same here with the thumb sucking, same thing, open bite, open bite. Okay. So So again, we spoke a little bit about malocclusion, and we said that there was a class 1 malocclusion, class 2, and class 3. And I think this was discussed in your discussed in DNA 108 or dental science course. So, we have to think back and kind of relate to that a little bit. Just get this in. All right. And a little bit of a cartoon version from your textbook, from the Modern Dental Assisting textbook, from table 60-1 of what we talked about. And here, this is what you saw in your dental science course. So as you can see, you have your normal occlusion, you have your class 1, you have your class 2, and then you have your class 3. And all of it is reliant on a certain cusp in the mouth. And you can also see how the anterior orientation is as well, especially the canine. Okay. And then if you remember, we also have lines of occlusion, right? We've got this diagram showing the lines of occlusion, looking at the central groove of the posterior teeth along the almost the incisal edges of the anterior teeth on both the upper and lower jaws. Now in class 1, now you got to think back to that. This is the normal relationship with molars, but the anterior teeth will be out of alignment. So the molars are normal, but the anterior teeth are out of alignment. They're malpositioned or they're rotated. And then you have class 2. So this condition is known as distal occlusion because of the fact that the body of the mandible, the lower jaw, is in a distal relationship to the maxilla. As you can see here, it's more pushed back. Okay. And then, of course, we always have that mesiobuccal cusp of the maxillary first molar as a reference, because now that this is pushed back, what happened is this cusp right here, is in the space between the second premolar and the lower first molar. So it's just something you got to kind of consider or look at. And then, of course, you got your class 3, and that's a little bit of the opposite. And this is considered a mesoocclusion. Mesoocclusion, it's when the body of the mandible is abnormally pushed forward or mesial to the maxilla. And as you can see, now you have now the cusp no longer rests between the premolar and the molar, but now it is distal to the first molar of the mandible, this cusp, okay? And look at the anterior teeth. It's almost like a bulldog appearance. The lower anterior teeth are pushed forward in front of the maxillary anterior teeth. So crowding is the most common when it comes to malocclusion. Crowding is the biggest issue. It's misplacement of teeth out of their normal position, as you can see here. But then you also have something called overjet, which is also pretty common. And overjet is an excessive protrusion of these maxillary incisors, and you get this space. So I like to think of it as a jet airplane that flies that flies from the facial surface of the mandibular incisors, and then they fly into the incisal edge or the lingual surfaces of the maxillary anterior teeth. Okay, so you do see some horizontal distancing between the incisors. Okay. And then you have what's called an overbite. An overbite is when you want to look at the vertical aspect in between these two teeth. So in this one, over jet, we looked at the horizontal aspect, looking at it from the side. But then when you look at the front of the teeth, you want to see the vertical overlap, like how much of the distance it is from the mandibular anterior incisal edge of the incisors to the maxillary incisal edge um, of the maxillary incisors right here. So this is often called the deep bite, deep bite. And then we already talked about the open bite. And then, of course, we also have a cross bite, a cross bite. And that's just simply a tooth is just not properly aligned with its opposing tooth. The mandibular tooth is buccal or facial to the maxillary tooth. That's a cross bite. All right. Here we have the horizontal overlap right here. And this is what I was telling you about the overjet. It goes this way. So it's the distance from here to here. And then when you have the overbite, it's the distance from this edge to this edge. Okay. That's overbite. All right. All right. So we want to talk a little bit about, managing the orthodontic problems. We do have corrective orthodontics to move the teeth and correct these malformations or malocclusions. And they can be anywhere from being a fixed impliance, meaning it's in the mouth, it doesn't get removed, or you have a removable appliance, like Invisalign, you actually remove it, or you got to have actual orthognathic surgery, So some of these things can be pretty intense or very much involved. Okay. No matter what, when it comes to orthodontic records and treatment planning, you really got to remember we talked about this, the medical history and dental history. That's what's really important. We also want to know the physical growth evaluation. How old are they? What point in life are they at? Do they still have their baby teeth? Do they not? What are their social behavior evaluations? Okay. What is the clinical exam? And what are their diagnostic records? Okay. With the clinical exam, we always want to know their proportions. Okay. We want a front analysis. We want to look at the symmetry, the size proportion, the vertical proportion. We want to look at their overall profile, meaning look at the jaw proportion, the lips. Okay. Do the lips protrude? Do they not? What is the vertical facial proportion? We also want to look or evaluate their oral health. Do they have a lot of cavities? Are they prone to gingivitis? We also want to look at the jaw function and the occlusal function as well. With diagnostic records, you want to look at photographs. They consider photographs diagnostic records, radiographs. Remember the models you did, the diagnostic models. Photographs are useful as an aid in identifying the patient, treatment planning, let's say for a case presentation or even documentation, or even simply to show the patient, this is how you look, this is how you present with. And it's great for before and afters. Let's say you're done with the orthodontic treatment. You want to show the patient, this is how you look before and this is how you look after. So there's many benefits to records. Photographs, we want to look at the side view or the profile view and the frontal view. So how they look from the front and how they look from the side. A little bit of a mugshot, a little bit. That's what people have called this. So there's 3 standard intraoral photographs, and they're all, they're also routinely taken. Okay, 3 standard intraoral photographs. You have the full direct view, the maxillary occlusal view, and the right buccal view, And this is the facial analysis that I talked about from the side and then the frontal aspect as well. Now, you remember taking a panoramic radiograph in the clinic, and you remember the red lines that appeared. And the red lines that appeared often gave you, the distance between from one tragus of the ear to the other tragus of the ear, or one commissure of the lip to the other commissure of the lip, or, one part of the eye to another part of the eye. Same with the nose. Okay. And we also look at angles of how they look from the side. And remember, this is really important because what's going to happen is as they're done with their orthodontic treatment, there's a possibility that a lot of these things are going to change. Okay, again, these are extraoral radiographs, or rather photographs of how this patient looks from the side and front. And these are your intraoral photographs. And this is a frontal view, a maxillary occlusal view with the mirror on the bottom, and a right buccal view. All of these are done with mirrors. And then we already talked about the panoramic radiograph, but that's another standard that orthodontists use. They take a panoramic radiograph and they take a cephalometric radiograph. With the cephalometric radiograph, it's also a extraoral radiograph, just like the panoramic, and it makes it possible to evaluate the anatomic basis for malocclusion, as well as the skull, bones, and soft tissue. And it also helps us to analyze. So what we ultimately do is we analyze this type of radiograph. And it has computerized drawings, and it has areas where we can place points such that we can measure the size and the status of the skull in terms of their growth development for the patient. And this is how a Ceph looks like. A Ceph is short for cephalometric radiograph. So this is how a Ceph looks like. You can see it from the side, whereas a panoramic is more of a pumpkin view, mostly from the front. Okay. And these are landmarks, and those are the points that we were talking about: point A, point B, point C. Okay, lots of angles, lots of things go into this, as well as this analysis. Okay, the casts, of course, those are open for space analysis. We want to see the distance from one tooth to another. We want to see how the teeth come together, and it's very precise. And as you see, and you did this in dental materials, and it just basically tells you how does the patient look beforehand. And then a case presentation, this stuff really helps with case presentations, along with when you want to present the treatment plan or a cost estimate to the patient. And at this visit, a case presentation is really helpful because it'll give you all the things in one: a treatment plan, radiographs, photographs, diagnostic models, everything. It's all together in one. And then, of course, you come up with a financial arrangement where maybe the patient has to pay for a payment plan. Let's talk a little bit about intraoral instruments. Here you have the orthodontic scaler. Okay, this can help you place brackets, remove the elastic rings, those little rubber bands you see around brackets, and also to help you remove any type of excess cement or bonding material. And then, of course, this is double-ended. A ligature director, this is used to guide the elastic or wire ligature tie around the bracket and to tuck the twisted and cut the ligature tie under the arch wire. See, it's a little notched area, as you can see here. And then you have a band plugger. One end is kind of similar to a condenser, and the other one is similar to like a scaler of some sort. This helps to seat the molar band, and for a fixed appliance. Here's your bite stick. Okay, it has this little triangular stainless steel part. It's used to help also to seat a molar band when you're doing a fixed appliance. And then you have bracket placement tweezers. You might have seen this before. These are bracket placement tweezers. When you let it go, it stays engaged, okay? And these little brackets are very tiny. So these type of tweezers really become helpful. Overall, you do have a slew of pliers and cutters and stuff. So here you'll have your bird beak pliers, you'll have your contouring pliers and your Weingart. You'll also have your three-prong pliers. This is called your posterior band remover. Of course, this is all in your textbook. Here you have your ligature pin and ligature cutter. It's pretty sharp. You got your Howie pliers or your 110 pliers that you have seen before. And you got your wire bending pliers and your ligature tying pliers. Yeah, so all of this is here. You can take a look at this. Some of the names kind of tell you right then and there what they do. It's pretty obvious, but you can review this on your own time. But no matter what, always remember that you have to consider whether the patient is having a fixed appliance or removable appliance, or maybe even a combination of both to move the jaw or the teeth. And part of those appliances are fixed separators or even orthodontic bands. And this is your fixed appliance. As you all know, as braces. Notice you can't take these out. They are cemented in. It's a combination of brackets. It's a combination of an arch wire. And this allows the orthodontist to help move the teeth in different directions: mesially, distally, lingually, facially, apically, occlusally. So they're at liberty to move your teeth anywhere. And that is the beauty of this appliance here. Okay. So in the sequence of appointments, first you got to place your separators. And we're going to go over this in lab, you want to place your separators because you want to create space. Then you want to place bands on. You're going to cement those bands. Then you're going to take brackets and bond those on. Then you're going to put the arch wire along with the rubber bands on top of those. Then you're going to do an adjustment check. You're going to remove the appliance. And then ultimately, you want to check the retention of teeth, maybe through a retainer. Your book mentions another category called separators, and you're going to learn this a little bit in lab. They look like these rubber bands, and you take an instrument, right, and you basically place it in between the teeth, and you can use floss or you can use this instrument. I actually like floss. And what you're going to do is you're going to keep this placed here for around 1 to 2 weeks before you place bands around because you're trying to create some space. The bands, as you see here, this is your band. This has a bracket attached, but this is your band. After you take the separator out, you're going to cement these bands in place. And usually you're going to use a band pusher, okay? And you're going to cement those bands. Usually you cement it. What are you going to use? You're going to use something with fluoride in it. So usually glass ionomer, if you remember and think back to your dental materials class, that has fluoride in it and it adheres to the enamel because remember, these teeth still have enamel on them. It's not like you're making a crown. Your crown had only dentin and no enamel. So this is different. This has enamel intact and you do want fluoride releasing properties. So you're going to use glass ionomer as your cement. Okay. Other possible attachments on those bands, we don't see these that often, but they do exist. You do have headgear tubes. Headgear tubes look like this. They're round tubes and they're placed on the maxillary first molars. And it's like an inner bow of a face bowl appliance. Okay. And then you got edgewise tubes, you have labial hooks, and you also have lingual arch attachments. This is how I think you guys are commonly know of this, bonded brackets. Okay, so before you place the wire across, you bond these brackets in place. And as you can see, there's a little notch. The arch wire will slip through this, and then a rubber band of any choice of color that you want will go on top. That's why you also see these kids or teenagers will have a certain type of color that they choose to put on to keep the arch wire in place. All right, this is how it looks up close. And these are the arch wires I was telling you about. They come and they look like this. And then the orthodontist can choose to place any type of kinks in these in order to maybe move a tooth a certain way. And then again, remember the strengths of the wire, they do differ. So, you can get thicker wires, thinner wires, they do differ. The types of arch wires in terms of material can be stainless steel, beta titanium, OptiFlex, nickel titanium. So, there's different properties for this. But the shape of the wire also really matters. When you have a round wire, like meaning if you were to cut this wire across and look at the cross section of it, it has a different function. Whereas when you have a square or rectangular wires, square and rectangular wires are usually used for the final stages of movement, whereas round wires are for intermediate stages, for an open bite, etc. Then you want to ligate the wire. So after the arch wire is placed, remember I talked to you about some sort of rubber band looking things. They come in different colors. So these are your ligature ties, you'll also see, maybe if you ever work for an orthodontist, they'll have the Kobayashi hooks that look like this. For the attachment of elastics, that you have an actual rubber band that goes around this to the upper arch, Okay, just like this. Okay, so something very similar to this. Power products, you got elastomeric chain ties, you got elastics like rubber bands, elastic threads, comfort tubing. There's a lot of things that go into play because you're dealing with the mechanics of movement. That was a previous cartoon version. This is an actual picture. You may have seen this maybe in some of the patients you've been seeing in your clinical rotations, or maybe you had this yourself as well. Now, can you imagine oral hygiene? It's going to be really difficult to clean these teeth, even on the patient's own when they're brushing. They do their diligence, and you can see this here. Look at the gums of this patient. They are rolled up. That is not good. That means this patient bleeds. Again, no judgment, but this patient bleeds when they brush and stuff like that because they're pretty puffy. Because that means that the patient's having a difficult time in cleaning these teeth, or maybe they're just not compliant. So they always have to use a floss threader because if you notice in the previous picture, they can't floss between these teeth. So they have to use a floss threader, something that goes underneath the brackets or underneath the arch wires. You got to brush your teeth at least once a day. Hopefully, you're doing it more than that. And after you're brushing, you're rinsing, you're swishing water to remove any debris, and you want to inspect your teeth to make sure they are spotless. Okay. These are things that, you kind of want to think about, like to avoid, sticky food, hard food, husk food, chewing gum, even bread. If you remember, you eat bread, that bread just like basic sandwich bread, that thing will get stuck all over your teeth. So they really have to be mindful of what they're eating. And if they want to eat whatever, that's fine too. But then they really got to make sure they brush. They really have to make sure they're diligent with that. Okay. Headgear, not that common, but headgear is an orthopedic device used to control growth and tooth movement. There are two parts. We mentioned the facebo and traction devices. The facebo actually, what it does is it stabilizes the maxillary first molar distally. You're kind of pushing it, you're moving it a certain way in the arch, but the traction device is an extraoral force. And this could be on the back of the head is the traction force. Okay, this is how it could look. Obviously, many orthodontists try their best to avoid this because of social aspects, psychosocial aspects. Sometimes they even have a chin cup here. Okay. Completed treatment, as the way it was placed on is the way it's going to be removed. So once the patient has everything removed, the band is then removed by breaking the seal of the cement. You want to lift the bands off, and then the bonded brackets are then removed by fracturing, by creating a fracture within the resin bonded material. And then, of course, you then want to have retention, right? And how are you going to do retention is by an appliance. Maybe you'll use a Hawley retainer appliance or maybe even a lingual retainer appliance. The lingual retainer appliance is fixed. That's when the brackets go on the lingual surface and they are bonded on that, okay? So what is the purpose of retention? It allows the gingival tissue to readapt to itself. It keeps the teeth in the desired position, keeps them from getting unstable. It controls the changes due to growth after treatment. Because remember, the teeth want to go back to the way they are naturally from the beginning. And the purpose of the retainer is to prevent that from happening. Okay, here's some interesting pictures. Here you have all of these are removable appliances. And as you can see, here's your fixed lingual appliance on the lingual surfaces here. Okay, orthodontic positioner, it retains the teeth in their desired position, permits the alveolus to rebuild support around the teeth, and it also massages the gingiva. Pretty thick. All right, this is how a trace setup looks like. And these are videos for you to review at your own time. Feel free to look at them. They're pretty interesting, but it's something that you can view at your own time. And these are my references. Okay. All right. Thank you.